Hello, it's my pleasure to give this presentation today. I'm Byoung-Eun Yang, Harlem University Hospital in South Korea. The topic of today's presentation is the latest update of digital bespoke orthognathic surgery in Korea. I have nothing to disclose. Recently, the term bespoke medicine has emerged. It is a movement to better fit treatment to the individual patient. That's why I applied this bespoke medicine to the orthognathic surgery and named it Bespoke Orthognathic Surgery. Recently, FACEGIDE system, that is one of bespoke orthognathic surgery system, has been established in Korea. This type of technology is emerging from several medical companies around the world. If so, I will explain the difference from the conventional method through the recent case of bespoke surgery in Korea. A 22-year-old female patient visited the hospital. She showed skeletal class 3 malocclusion. Surgery was planned as a typical class 3 skeletal malocclusion. Treatment. Surgeons should keep these three keywords in mind to understand digital surgery. The first is the merge, the second is STL, the third is reorientation. I will explain some of the merge process in detail. By the first step, we get the patient CT data and get the patient dentition data through scanner. The CT data and dentition data are combined to create hybrid image. This video is showing the process of creating this hybrid image, maxilla and mandible. The step is calibrate the CT after matching the ambiguous teeth area of the CT with the dentition image obtained by laser scanning. And then, reorientation can be based on the landmark of the upper skull part, which is symmetrical left and right, and is determined according to the surgeon's preference. If orbital area does not have severe malformation or asymmetry, you will be able to create the virtually reoriented face using both orbitale. If you look at this slide, the orbital limb will look at two lines, and then the image is rotated and the two lines appear as one line. And in this state, we hold the FH plane as a horizontal plane. This method may differ from clinician to clinician. A 3D digital twin image of the patient is obtained from the patient through the aforementioned merge and reorientation technique. A bone cutting line was set in this image. The maxilla was moved three-dimensionally. And then the customized plate were designed. And the mandible was moved corresponding to the maxilla moved. Bilateral proximal segment were also properly positioned. And then the osteotomy guide were designed so that virtual surgery of the previous slide can be performed. You can see the preoperative lateral view. The maxilla is moved. Customized plates are designed. After the mandible was moved, the genioplasty was performed. Osteotomy guide were designed. In 2018, we reported the yaw control of condylar head for optimal contact between the proximal and distal segment. At that time, in this article, the rotation point of the condylar head was designated as a medial pole of condyle. Recently, the rotation point was changed to the midpoint between condyle center and the medial pole. You can see the center of the yaw rotation point in the left condyle is set as the midpoint between the condylar center and the medial pole. You can see the rotation center in the axial view. You can see the rotation center in the sagittal view. You can see the yaw rotation center of the condyle in the 3D image. The condyle head was adjusted inward by about 1 degree with the rotation center fixed. The head of the moved condyle is shown as a red line in a comparison with the condylar outline before movement is performed. The movement of condylar head is evaluated in the axial view. The movement of condylar head evaluated in the sagittal view. In this way, the right condyle is rotated inward by 3 degrees. The left condyle head rotated inward by 1 degree. You can see the proximal segment before and after the virtual surgery. In the basal view, you can see the proximal segment before and after the virtual surgery. You can see the frontal view and profile view and the basal view after proximal segment have been moved. The proximal segment positioner is designed to finally confirm the position of proximal segment during virtual surgery. The important point here is that arm of the mandibular osteotomy guide and the arm of the proximal segment positioner must be designed to be placed in the same position based on the ramus. Its practical use is described in the article. Predictive hole placement concept is one of the important features of bespoke surgery. This case is a video of another patient. Let me explain briefly. The customized plate is aligned appropriately to the pre-drilled holes and fixed to the patient bone. The customized plate and relative bony anatomy will now be positioned as intended in the virtual surgery. Surgery was performed using osteotomy guides and the patient customized plate. At the time of the initial plan, we included genioplasty. However, it was changed to not perform through evaluation during surgery. This slide is a right profile view. This slide shows virtual surgery and actual surgery. This slide shows virtual surgery and actual surgery on the left profile view. This slide is a basal view before and after surgery. You can see the ramus flare slightly modified. This is a fusion image of 3D CT before and after surgery. As initially planned, the PNS was moved upward and the mandibular distal segment was moved posteriorly. Let's look at the efficiency of bespoke surgery so far. The bone removal is minimized and the bone contact is improved. The good healing expected because of customized osteotomy guide. The core of this surgery is to fit the patient bone on this customized plate, which is to reflect virtual surgery on actual surgery. In bespoke orthognathic surgery, we used plates that are custom-made for individual patient for orthognathic surgery. The biggest efficiency of the bespoke surgery is to set the stable position of the mandibular condyle. In bespoke surgery, stable condylar position can be established using customized plate and the proximal segment positioner. We traced in condyle fossa relationship after surgery. There was no special problem in the right joint. There was no special problem in the left joint. Recently, there was an update of the FACEGIDE program used in the case presented today. Surgeons can now perform osteotomy positions that were previously set by requesting an engineer. To facilitate tracking of bone movement, 3D-dimensional coordinates of desired landmark are inserted. Various point settings are now possible for your control of proximal segment. Through bespoke orthognathic surgery, An average surgeon will be able to provide patient with good surgical result above average. Thank you for your attention.